So, let's talk about the fertility journey. It can feel, well, pretty overwhelming, right? It's a road filled with so many questions and a lot of uncertainty. But what if there was a doctor's guide for it? A step-by-step roadmap for those very first stages? Well, that's exactly what we're going to break down today. We're going to demystify the official medical guidelines and hopefully turn that uncertainty into a clear, actionable plan. So if you've been trying to start a family, this is absolutely for you. We're going to walk through the exact evidence-based process that your doctor follows, right from that first conversation to the first round of tests. It's really all about taking the guesswork out of your next steps. Okay, first things first, let's get the language right. The official medical term at this stage isn't actually infertility, it's subfertility. And really, it's just a neutral clinical term. All it means is that pregnancy hasn't happened after a full year of trying. This definition is the official starting line for the whole diagnostic process we're about to jump into.
And here's our game plan. We'll cover when the guidelines say it's time to seek help, what actually happens at that first doctor's visit, and the two crucial tests they'll probably run. Then, we'll see how those results lead to a real fork in the road, how doctors calculate your chances, and finally, what your path forward might look like.
All right, let's dive into the biggest question of all. When is it actually time to go see a doctor?
And the answer, according to all the official guidelines, is super clear. 12 months. 1 full year is the standard time frame. Before that point, a spontaneous pregnancy is still considered pretty likely for most couples, but once you hit that 1-year mark, that's the recommended time to start the conversation with your doctor and get the investigation going.
Okay, so you've crossed that 12-month line and you've made the appointment. What now? Well, this first visit is all about gathering information. It marks a really important shift, right? You're moving from just trying to actively diagnosing.
So your doctor is going to start with a whole bunch of questions for both of you, a detailed medical history. They'll ask about things like how regular your cycle is, any pregnancies you might have had before, and your medical background, including things like past infections, especially chlamydia, or any abdominal surgeries. They'll also get into practical stuff like lifestyle factors and how often you're having intercourse during that fertile window. It's a really comprehensive look at all the potential pieces of the puzzle.
After all that talking, a physical exam might be next. For the woman, this helps the doctor check for any anatomical or hormonal signs. For the man, it's usually done if the first round of tests shows something unusual. It's really just a routine step to get the full clinical picture.
Now we get to move from the conversation to the concrete evidence. And what I think is so great about this guideline is how it just cuts through all the noise and focuses on just 2 key high-impact tests to get started.
And here they are, the 2 pillars of this initial investigation. For the male partner, it's a sperm analysis. This is all about checking the health of the sperm, especially its ability to move, which is called motility. And this is crucial because poor sperm quality is a factor in about 1/5 of all cases. Then, for the female partner, there's a chlamydia antibody test, or CAT. Now, this isn't looking for a current infection. It's looking for antibodies that show if you've had one in the past, because that can sometimes cause scarring in the fallopian tubes.
And you know what's really interesting here? It's what's not on the list. The guidelines specifically say to avoid some of the tests you might have heard of, like basal temperature charting or the postcoital test, at least as a first step. And why is that? Well, it's because in a primary care setting, they're just not considered reliable enough. They don't give the clear, objective data that's needed to make that next big decision.
So once the results are in from the chat, the exam, and those 2 key tests, you come to this really critical decision point. This is where the path forward suddenly gets a whole lot clearer. So the huge question is, how does your doctor take all this information and make sense of it? Well, those results are going to point you down one of 2 very different paths. And this just lays out the logic perfectly. If there's a clear, obvious issue, what the guidelines call abnormal findings, the path is totally straightforward. You get a direct referral to a specialist for more tests and treatment. But if everything comes back looking normal, you head down path 2. And this is where it gets really fascinating, because your doctor then uses a special tool called a prognostic model to actually calculate your specific chances of conceiving naturally in the next year.
So, what on earth is this prognostic model? Well, think of it less like a crystal ball and more like a really sophisticated weather forecast for fertility. It's based on data from thousands and thousands of other couples who've been in the exact same spot.
Basically, it takes all that key info that's been gathered and plugs it into this proven algorithm. The most important factors are the woman's age, how long you've been trying, whether you've ever been pregnant before, and, critically, the results from those two big tests, the CAT and that sperm motility percentage.
Let's see how this actually works. Okay, so imagine a 25-year-old woman. If her partner's sperm motility is at 20%, her chance of a spontaneous pregnancy in the next year is a pretty solid 36%. But watch this. As we bump that motility up to 40%, her chance jumps to 40%. And at a really strong 60% motility, it hits a very promising 45%. You can see it's a clear positive connection.
Now hold that thought and look at this. We're going to change just one variable, the woman's age, up to 35. Suddenly, that same 20% motility gives a 23% chance. 40% motility gives a 27% chance, and even 60% only gets to 31%. It is the exact same sperm data, but look at how much lower the percentages are across the board. This just powerfully shows you how big of an impact age has in the model's calculation. It's a massive factor.
So, the model spits out a percentage, but what do you actually do with that number? Well, the guidelines are great because they translate that percentage into one of three really clear recommendations. And here they are, laid out nice and simple. If your chance is calculated to be over 40%, the standard recommendation is to wait another 6 to 12 months. Why? Because a natural pregnancy is still the most likely outcome. If your chance is in that 30 to 40% yellow zone, the policy is to discuss the options with your doctor. And if the chance is below 30%, the guideline recommends a referral to a gynecologist to look at next steps. Now, if you do fall into that weight category, I get it. It can feel frustrating. But it's so important to know this isn't your doctor brushing you off. The guideline explicitly says that even top fertility specialists would give you the exact same advice. It's a sound medical decision based on the high probability that nature is still very likely to take its course.
And no matter what stage you're at in this process, the guidelines point out two key lifestyle factors that you actually have some control over. They note that women who smoke tend to have a lower chance of pregnancy, and that a BMI of 30 or higher is linked to it taking longer to conceive. So these are concrete, actionable things you can always talk about with your doctor.
So, there you have it. We've walked through the official map, from that 12-month starting line all the way to the prognostic model that helps calculate your odds. It's a journey that's really designed to replace uncertainty with a clear, structured, evidence-based process. Knowing this path is out there is the first step. The only question left is, what's yours?